Good evening, everyone. Thank you so much for joining us this evening. My name is Anne Marie Crow, and I'm a emeritus board member of the Stanford Historical Society. I've also had the pleasure of being a member of the Vibrant Program Committee for a number of years. Today is one of those special days when two passions in your world collide. In my professional life, I serve as a senior leader in Stanford's Medical Center Development Team, often standing side by some of the most extraordinary minds in medicine. This evening's panelists are perfect examples of that. It's something my 22-year-old communication major self would never have imagined, particularly as I felt that I was surely the only person ever to graduate from Stanford never taking chemistry or physics or anything nearing the medical field. But I think that's truly part of the magic of Stanford and allowing us all to come together with a common purpose. To start us off on tonight's adventure, it's my esteemed honor to introduce Dr. Joseph Wu, who is a nationally recognized heart surgeon and leading researcher in new approaches to cardiovascular care. Dr. Wu began his service as the Norman Shumway Professor and Chair of the Department of Cardiothoracic Surgery at the Stanford University School of Medicine on January 1st, 2014. Dr. Wu, who was born in Missouri and raised in New Jersey, earned a bachelor's degree from Massachusetts Institute of Technology and a medical degree from the University of Pennsylvania, where he conducted his postgraduate surgical training. Dr. Wu also completed a postdoctoral research fellowship in novel molecular strategies for the attenuating myocardial ischemic injury, for which he won the American Heart Association Vivian Thomas Young Investigator Award. I practiced that too, Dr. Wu, I'm sorry. Dr. Wu joined the Penn faculty in 2002 as the director of the Minimally Invasive Cardiac Surgery Program. He has significantly advanced the field of complex valve repair and serves as principal investigator for several clinical device trials and translational scientific trials, such as delivering stem cells during coronary artery bypass grafting and mechanical heart pump implantation. He has helped advance the field of complex valve repair and has developed several innovative new mitral and aortic valve operations. One of Dr. Wu's esteemed colleagues who oversees the Cardiovascular Institute of Stanford, who by the way is also named Dr. Wu. I don't know if Joseph Wu knows this, but we call him 00 Wu in our office. So he's like the Bond of cardiovascular medicine in our mind. Sorry, Kathy, I don't know if you ever shared that, but now the secret's out. He's that cool, actually. So Dr. Wu, who heads the Cardiovascular Institute, shares, I think he epitomizes the rare breed of cardiothoracic surgeon who's a triple threat. He excels at academic medicine, and clinically, he's world-renowned in mitral valve repair and the use of mechanical devices. From a research perspective, he's one of the few CT surgeons in the world who has had continuous NIH funding. As an educator, he is passionate in training and the next generation of thought leaders in CT surgery. Nationally, Dr. Wu chairs several committees and is a member of the editorial board of the Journal of Thoracic and Cardiovascular Surgery and a guest editor for Circulation. I personally am also very proud to share that Dr. Wu and his wife have two children who are both currently undergraduates at Stanford. Dr. Wu is an extraordinary partner who advanced the field in ways that even this fuzzy Stanford graduate can understand, even if I can't always pronounce them perfectly. He's the perfect person to lead our reflection today on the storied history and the exciting future of heart transplant at Stanford. Please join me in welcoming Dr. Joseph Wu.
Thank you, Anne-Marie. That was an exhaustive introduction. I want to first extend my gratitude to the Stanford Historical Society and to all of the participants for the unique privilege of speaking tonight, and also for the distinct honor of hosting and introducing a truly distinguished panel of Stanford professors. You'll learn more about them as we go along. May I start with something a little bit different and ask for a show of hands of anyone that was here around Stanford in January of 1968. Wonderful. Okay, great. Thank you. So I'm actually going to start a little bit earlier. So with the help of former chair, Dr. Bruce Reitz, who has a vault of a memory, we were able to put together this history of thoracic and cardiovascular surgery at Stanford over the past 100 years. There's a rich legacy and tradition here, and it starts with the original Stanford Medical School up in San Francisco. I won't ask anyone if they were around San Francisco in 1914, but I think many of you were around when the new hospital was built here on campus in 1959. So this story is really about the individuals on this slide. Of course, Dr. Norman Shumway, MD, PhD, who came here from the University of Minnesota after conducting his training at what was then the epicenter of heart surgery in really the entire world. And Dr. Shumway trained many, many famous heart surgeons. 3 of them are on this slide. Dr. Edward Stinson, who I'll tell you a little bit more about, who ran the heart transplant program for many, many years, and who was also there scrubbed with Dr. Shumway during the very first heart transplant. Fortunately, Dr. Stinson is still with us. He's healthy. He's been retired for about 20 years, so it's a little hard to get him to come out of retirement for events, but he's doing quite well. And then with us today is Dr. Bruce Reitz, the Emeritus Shumway Chair, Professor and Chair of the department, who not only led the Stanford Department of Cardiothoracic Surgery, but also was during his career the Chief of Cardiac Surgery at Johns Hopkins, also a world-renowned cardiac surgery program. Dr. Phil Oyer, who's with us, led the heart transplant program in the more recent years, and also performed the world's first artificial heart as a bridge to heart transplantation. And I'll show you quite a bit more about that. And then finally, and most importantly, Dr. Sharon Hunt, who was there for the very first heart transplant. She was a student here. She was on the campus and really was instrumental in the blossoming of heart transplantation, with the introduction of new immunosuppressants and very sophisticated medical management of the post-heart transplant patient. So today we'll go through and talk about heart transplantation, heart-lung transplantation, and mechanical circulatory support, or what we call artificial heart devices. So let's start with heart transplantation. This is that famous day and a photo from the operating room. And it's a little hard to see, and I'm told that the photo's actually flipped, but Dr. Shumway is scrubbed there with Dr. Edward Stinson, and they're putting in the heart. So what I thought I'd do is I'd show a little tiny video clip to see what the press had to say about that day, and also hear about what Dr. Shumway had to say about that day. So let's hope the sound works, okay?
1968, at the Stanford Medical Center, Norman Shumway and his transplant team conduct the first adult heart transplant in the United States. Afterward, Shumway says, "This is only the first step. Now the real work and concern begin."
We were all ready to go. We had a patient selected, and we needed a donor and so forth. So it really, the main thing is to get the project going and to do it properly thereafter.
So we heard it directly from him. So this is the report of the initial clinical experience, and there is case 1, a 54-year-old man, admitted on January 5th. And we'll hear a bit more about this gentleman. So as I mentioned before, the real explosion in adoption of heart transplantation had a lot to do with the ability to avoid rejection of the organ very effectively. And this is an article written by Dr. Hunt in 1990, looking back at the experience at Stanford before and after the introduction of a very critical agent called cyclosporin, or here referred to as Sandimmune. And those two lines show a marked difference in survival of patients who did not have cyclosporin and patients who did have cyclosporin. And this really changed the entire face of transplantation, not only in heart, but also in other organ systems. Heart transplantation grew very rapidly in the 1970s and into 80s, and you can see here, this is the worldwide experience of heart transplantation, adult and pediatric, throughout the world, divided by North America, Europe, and the rest of the world. And you can see here that the lion's share of heart transplantation is still being done in North America, and Europe totals up to a little under what North America is doing, and then the rest of the world is a very small fraction. This really hasn't changed significantly in the last 2 decades, and part of that is because of donor limitation. That is, there's only a certain number of donors available. There are many, many more patients waiting for heart transplants. So I'm going to show you a few of the things that are being done to try to increase the number of donors available. This is just an example of a heart that was working fine in the donor, but had a significant defect in the aortic valve, one of the major valves inside the heart. And this heart was turned down by all other transplant centers, and we took this heart and we actually went and repaired the aortic valve, and that worked fine, and so we rescued an additional donor that way. We've also done this for the mitral valve. This is a very commonly diseased valve and one that we're very comfortable operating on and repairing, and this is an example of that allograft in an ice bucket on the back table undergoing a mitral valve repair. This is the best exposure you'll ever get to the center of the heart, and we did a mitral valve repair operation and reconfigured it the way it's supposed to look, and then put that into the recipient, and that worked fine. So again, another example of a rescued donor allograft. We've done this with coronary bypass, tricuspid valve repairs, a variety of different operations where we actually operate on the heart that we're going to transplant in. What else are we doing in heart transplantation that's interesting? This is a paper written by some of our pediatric surgeons, although this is being applied to adult patients as well, and this is something that Dr. Reitz helped to pioneer very early on. That is to do combined heart-liver transplantation, but to do it in a very unique way, very different than how other centers in the United States do this. In fact, how I remember doing this when I was back at the University of Pennsylvania. In this case, the organs are brought back together as a block. So this is an example of a patient, and I promise there won't be any active bleeding, and I'll warn you, there's only one slide that I'll warn you beforehand. But this is an example of heart disease and liver disease, and in a patient with a very complex congenital condition that the patient was born with. And we took out the heart and the liver, and then you can see a giant team here. So there are multiple surgeons operating there at the bedside, and then another set of surgeons operating on the set of organs, preparing those organs. This is what it looks like. That's a heart attached to a liver. And then everything is implanted all at once. So that's combined heart-liver transplantation. What else are we doing that's interesting? Well, we're using 3D printing technology to, in advance, print the internal thoracic anatomy of patients, so we can actually look at it and see what would the inside of a patient's chest look like to help us plan the operations. This is an example of a very complex thoracic inlet in a patient. Okay, so I'm going to give you the warning. The next slide is just slightly involved, and if you're a little bit afraid, please cover your eyes. So this is an organ perfusion system. This is like the next greatest thing. So right now, when we go and do heart transplantation, we go somewhere else, we harvest the heart, bring it back in an ice bucket. Well, that sets certain limits on how far we can go, how long we can keep the heart outside of one body before we put it into another. This is a system which allows us to extend that time, where you actually take the heart and you hook it up to a machine that pumps blood into the heart and keeps it alive and actually beating. And this has been used in a variety of clinical trials, but most interestingly, it's been used in the Australian outback, where they have to go quite some distance before they can reach, say, a medical center, and then they have a lot of travel to get back, and they might need, say, 3 times the amount of time that you would normally need in a more metropolitan area. So again, if this is concerning, please cover your eyes, but I want to show you what this actually looks like live. So there's the case, and there's a heart beating inside, and then we're actually going to open this case and show you. That's a live human heart attached to the machine, beating, and it's kept alive, and you can actually transport this across the country. So this is going to revolutionize heart transplantation. Okay, so I just wanted to give you an idea of how things have been going with heart transplantation over the last 5 decades. So you can see on the very left-hand side of the slide, 1968 was the first year, as you know, and really the explosion, as I mentioned, occurred with cyclosporin, and Dr. Shumway set his all-time record of 65 hearts in 1986. And it took us 29 years to finally match Dr. Shumway's all-time record. And that's all the way down there in 2015, under Dr. Phil Oyer's leadership, we did 67 heart transplants, and last year we did 70. And that's made us one of the highest volume heart transplant centers in the country. So we were very fortunate to celebrate that 50th anniversary just a few months ago. And we were able to invite an international panel of experts on heart transplantation, heart-lung transplantation, and artificial hearts from throughout the country, Europe, and Asia. And you can see there, Dr. Reitz. Sitting next to Dr. Reitz is actually Dr. Sarah Shumway. That's Dr. Shumway's daughter, who is a heart surgeon at the University of Minnesota. And to Dr. Reitz's left is Dr. Edward Stinson, then Dr. Phil Oyer, and Dr. Sharon Hunt. So let's move on to heart-lung transplantation. So this is the landmark article. And with heart-lung transplantation, Dr. Bruce Reitz actually set an all-time world record, being the first person in the entire world to do a successful heart-lung transplant right here on the Stanford campus in 1981. And this is the initial description in the New England Journal of Medicine in 1982. This is an example of a heart-lung block. And because of the precedent that Dr. Reitz set here at Stanford, we, to this day, continue to be the busiest heart-lung transplant center in the country. We do more than any other center in the country. So I want to tell you about something that's really unique in heart-lung transplantation. This is the concept of Domino, and this really speaks to how precious these organs are. They're so rare that sometimes you have to take one from one person who's alive and give it to another. So what are we doing here? We have in the center a patient with lung disease who needs new lungs, but for some anatomic reason can only undergo a heart-lung transplant. So we go and get a donor, bring the heart-lungs back, and plan on doing heart-lung transplant. Of course, we dispose of the lungs that are diseased, but guess what? The heart is actually a normal heart, just anatomically perhaps in a strange position, and we're not able to do just lung transplantation. So in that case, we have to do heart-lung transplantation, but we have a heart that actually is okay. So we domino that heart into another human being. The ultimate recycling. Okay? Well, this sounds like a really exciting new innovation. But guess what? Dr. Reitz invented this in 1989. And I remember reading about this in medical school. I was in medical school when this paper came out, and everyone said, you gotta read this. This is really unbelievable. And that was the last time I heard about domino transplantation, back in medical school. And then all of a sudden, in 2016, we had this patient who had a disease that made it impossible for us to treat her lung disease with just a lung transplant, and we needed to do a heart-lung transplant. And lo and behold, we had a potential recipient for her heart. And so we went ahead and did the first heart-lung, heart domino operation in the United States in 20 years. No one knew how to do this operation. Dr. Reitz was probably one of the last people to do this operation, and there were really no instruction manuals out there. I just remembered something from medical school. So luckily, we had a lot of great teams with us. We did that heart-lung transplant, and this is the resulting x-ray, and you see the heart's in the center now. But this was a very interesting situation because the two patients who we obviously kept separated said, we really want to know how the other one's doing. And so we thought about it and we said, well, why don't you both get healed, go home, be with your families, and then we'll bring you back together when you're healthy and have you meet. And if you're okay with it, we'd like to do this with the media so that we can make people aware of how rare donor organs are. So rare that you, a living person, had to give your heart to another person. So we did do that, and we did that with the press on March 18th, 2016. And they met each other for the very first time. And it was a very heartwarming event. And I'll say two things. One, the title was Domino Donor Surgery Saves 2 Lives, number one. And you'll see there that Michael Fowler, one of the heart failure cardiologists, was there, and he's doing all the talking. So anyone here that knows Dr. Fowler will realize that this is perfectly in line and in character. But there's something else that was really very unique, something that never happens in the world. If you donate your heart to another person, this is the only time in the world where you can actually listen to your heartbeat in another human being. So they've stayed friends, and they've actually stayed very involved with us in trying to bring awareness to all of the public in terms of the scarcity of donors. Let me finish with mechanical circulatory support. This is the landmark paper that Dr. Oyer wrote about the very first patient in 1984 and the subsequent 5 patients where they actually had heart failure and they needed to implant an artificial heart to allow that patient to survive long enough to get a heart transplant. First time this was ever done in the world, done right here at Stanford in 1984 by Dr. Oyer. Well, those devices have changed quite a bit. That device I showed you before was about this big, and it sat on the outside of your body. And over time, we've moved those devices inside the body. This was the first one, and this was about the size of kind of a bread plate, maybe a dinner plate, sitting inside your abdomen. That's the first generation. And then the second generation could sit sort of underneath your ribs. The third generation can fit inside the palm of your hand and sit inside the sac of your heart. And then the fourth generation is the size of your thumb, and that can sit inside your heart. And now the fifth generation, coming soon, is the size of a AA battery, and that doesn't even have to go near your heart. It can just sit in a pacemaker pocket. So for anyone out there that has a pacemaker, this device is actually smaller than your pacemaker and can take over the function of your heart. So what else is exciting in artificial hearts? Well, we all know that we can charge our wireless toothbrushes and our phones by just placing them on a charging pad. Well, we've also developed technology where we can put that charging pad inside of a patient, and you can put the charging device right over their skin and charge right across their skin. So that's available. But what's going to be really exciting is when the batteries and the charging coils and the chargers become super efficient, such that the charging devices can just be scattered around your home and maybe in this auditorium. And you can just walk around and you'll be charged from the ambient wireless energy. That's what's the future. And then finally, let's talk just one moment about regeneration. Can we actually get the heart to rebuild itself? Well, we can't quite do that yet, but we can use artificial hearts to help recover the hearts somewhat, to rest the hearts a little bit, and then deliver stem cells into the hearts. And we're doing this. Stanford ran, as the national center, a trial of patients who had a sort of option to get an artificial heart, and then in a prospective, randomized, placebo-controlled, double-blinded manner, received either stem cells or culture medium. And we're waiting until these patients get unblinded, and then we'll see the results. That was the phase 2 trial I was talking about. That was prompted by this publication of the phase 1 trial, where they actually saw a difference. And this is the difference. Over the course of a year, these patients were brought back, and their artificial hearts were turned down, basically turned off. And we watched to see how long the patients could tolerate that. And over the course of a year, the patients who had stem cells were more and more able to tolerate that, and the patients who had control were less and less able to tolerate that. So that's what prompted the NIH to fund the phase 2 trial that Stanford was the national site on. So I'll just finish up with a couple comments. One is that we talked a lot about technologic advancement, whether it's in heart transplantation, heart-lung, heart-liver transplantation, or artificial hearts. And many of you out there can remember the very first mobile phone, something in a briefcase, right? And think about what your mobile phone looks like now and how much more powerful it is. Well, we never count out technologic advancement and never bet against the future, because you never know what the future is going to look like. Okay? So going back to something in history, I just wanted to show 2 times in Stanford's history, more recent history, when it actually snowed here. So this was in the 1960s. So some of you might remember this. And this was in the 1970s. You can tell by the pants. And so, sometimes there's the past, and then the future always looks bright. Okay, thank you very much. So it really is my privilege to welcome to the stage our distinguished panel. I've introduced them in depth and shown you a little bit about some of their academic and clinical accomplishments, but wouldn't it be great to hear their words? Can we welcome to the stage Drs. Oyer, Reitz, and Hunt, please? So we'll chat for a little bit, and then what I'd really like to do is to open things up later to the audience for questions. And I believe these are seasoned enough individuals that no question will be too difficult. Okay. So, well, let's start with Dr. Oyer sitting over there very quietly. So you told me a very interesting story once about donor hearts and how they used to be procured, and then when you changed to a different approach. Maybe you can relate some of that story about how we actually managed the donors before and then after that very interesting event that you described.
Yeah. Well, 1968 was a couple years before I arrived at Stanford. But the way donors were managed at that time was the donor had to be transported to Stanford Hospital, so they'd be in adjoining operating rooms, and then the teams would coordinate and when the recipient team was ready, the donor team would take the heart out, and we'd proceed to sew it in. So things could be done pretty quickly that way. The hearts were preserved just by putting them in a basin of cold saline. Ice cold saline, and that kept the heart alive enough to have time to sew it in and so forth. And the shortest time, those times were in the neighborhood of less than an hour from the time the blood stopped in the donor heart till it was reestablished flow in the other heart. So that was the situation from '68 when Dr. Shumway did the first patient until about 1973 or so. And of course, many families didn't want to go through the trouble of having their loved one transported, the whole body transported to Stanford. So that lost a lot of donors because of that, among other things. So in addition, just the logistics of getting all that done. So in '73, somebody had the idea, I can't remember who, that we could go somewhere else and take the heart out and just put it in cold saline and bring it back. And that happened sometime late that year. And I can remember that because I happened to be chief resident in training at that time on the transplant service. And so my junior resident went out, and the donor happened to be in Oakland, not too far away. And a guy named Jack Copeland, who went on to a long illustrious academic career, was the guy who went out to get it. But Dr. Shumway was going to go and help him take that out in Oakland. But Copeland went over in a helicopter, and Shumway, he didn't want to ride in a helicopter, so he decided to drive with Gene Dong, whose name you saw up there as one of the earlier participants in the lab with heart transplants. And so they, about the airport, they got a flat tire. So by the time they eventually made their way to Oakland, Jack Copeland had already taken the heart out and was just getting back in the helicopter. And so the heart came back, no problem, put it in, it worked fine. Shumway made his way back, and eventually you could see him looking over the anesthesia screen, watching the final stitches go into the thing. He made it back from Oakland by car. So since that time, it became much more convenient in many ways to get these donors from far, and that was only Oakland. But of course, we've now gone as far as Denver, maybe North Dakota and so forth, more and more in the last few years. And so that barrier has kind of come down. So that's kind of the way the so-called distant donor procurement came about.
I was interested in your heart in a box, Joe. Is this something that's actually now being done at Stanford?
It's not here at Stanford.
Mm-hmm.
It's at a few centers in the United States. Duke is one of the main clinical trial sites that has been using it. There's actually a parallel system. This is actually based off of the lung perfusion system, which is probably 10 years or 5 years ahead. And we do have that system here and are ready to use. So we'll be getting that soon. It's the same company, so we'll be doing this someday. But right now, we don't have quite the urgency for this device. I think for some reason, the way California's set up and how we're situated, we are not quite as donor limited and distance limited as some of the East Coast programs.
Well, that'll be a nice day when heart transplants can be scheduled electively the next morning rather than
right, and then bump the
starting at
elective
midnight.
cases. So Sharon, you were here on campus when that first heart transplant occurred. And may I please first say that if any of you want to hear an absolutely eloquent interview of Dr. Hunt by NPR, just type in NPR and Dr. Sharon Hunt, and you'll hear a great story. But we want to hear maybe just a little bit about what you saw, what the emotions were, what the excitement was.
Well, I was here on that day and in those days thereafter. I was a medical student, though, so I was very peripheral to all this.
And very young.
And
Yes,
childish.
very, very young.
Still is.
Yes. And yet I was working in the division, and so I knew all of the characters involved. And I remember the palpable excitement in the area with the press coverage, especially. There was so much interest in who was this patient, how did they do this, et cetera. There was actually one journalist our ICU in those days was on the second floor. And there was one journalist who scaled the wall with a camera and got up and got a photograph of the patient while he was still intubated there. So it was, all I did was watch that for about a day, and then I just wanted to get out of town and not watch that. That one photograph that you showed before, Joe, that had that initial press conference with Shumway and all the press, the guy standing up there asking the question was a young cub reporter named Tom Brokaw that year. He came because he lived around here and was close.
Yeah, a career-making event.
Oh, yeah.
Yeah. So, Bruce, I really want to spend some time talking about heart-lung transplantation. I've heard this story from you in many different versions. It's such a moving story, not only about the research work that you did, how you actually arrived at the model for the actual operation, and then maybe telling the audience a little bit about the patient. This was a very unique patient who was very involved in her transplant.
Well, Stanford in the 60s and 70s was really, in cardiac surgery, was just such an unusual place with Dr. Shumway as the leader, establishing really a culture within the department that was friendly to learning, as he liked to say, a term that he heard in Minnesota where he trained. But the concept was that everybody was thinking about how to solve problems and was going to the lab and doing things. And heart transplant grew out of that when Shumway and Dick Lauer in the lab were looking at preservation of the heart, and they decided to take it out one time and put it back in, and that sort of sparked his interest in heart transplantation. But there were so many things going on, and every resident fellow like Phil and I coming through that were interested in transplant would usually have a project. And I remember going to Dr. Shumway. Actually, the meeting was in the hallway, like most meetings with Dr. Shumway at that time. And I knew I was going to be finishing up soon. I needed a research project, and he suggested looking at heart-lung en bloc, because it was something that he and Dick Lauer had also wondered about and had done some early dog transplants. So I got started on that, and long story short, moving from the dog as a laboratory model, we went to small primates and monkeys. So we worked on the transplant procedure in the late 70s, and there's a synchronicity of events, which I think we're going to hear about from Sharon as far as immunosuppression goes, that then led to the possibility of heart-lung. So there was the very first patient was a woman from Tempe, Arizona, and not Tempe. Mesa, Mary Golke, and she had seen an article in a paper about heart-lung transplants in monkeys that we had presented at a surgical meeting in 1981. And it was, she had been told that her primary pulmonary hypertension, which had damaged her lungs and her heart secondarily, really had no treatment at that time. But if one could magically replace the heart and the lungs, then that would be about the only thing that could happen. But she put that together with reading about these monkey experiments and called Stanford Medical Center and wanted to talk to me. And this was about the same time that we were interested in trying to take it to the next step because of the cyclosporin immunosuppression. And one thing led to another, but she was accepted as a patient. It goes on to be a much more involved story, but I think interest of time I won't go into. But Mary Golke, and some of you who were around at that time remember 1981 in March when her transplant was done. And at that time, patients would stay in the hospital a long time. She was in for 3 months, and then 6 months altogether over here before she went home to Arizona. And Sharon, who by that time was a transplant cardiologist extraordinaire, if you will, became the first person to look after a successful lung transplant as well, and became Mary's primary transplant follow-up here at Stanford. So she had a hand in starting that area as well. But Mary then went on to return to work and lived for 5 years of good health. So
Yeah, and then she didn't die of a transplant-related issue.
She had no rejection in her autopsy. She died of more of a traumatic injury when she tripped and fell in her home, and may have ruptured her spleen, but it's a little unclear exactly how the events went, but her heart and lungs were actually free of any disease at the time.
It really speaks to your technical proficiency in doing the world's first operation, and then also Sharon's care that this patient lived so long and really had no issues at all with her transplant.
Well, she was and Sharon can expand on this, but having been a successful lung transplant recipient, she was inundated with letters and cards from people all over the country. I remember one picture of her sitting in her living room with cards and letters piled up about a foot tall. And she eventually responded to every one of them. Of course, not, promising anything, just telling what her experience had been. And it was at least a beacon of hope for a lot of people at that time.
And there is an autobiography.
And she wrote a biography,
Yeah.
yes.
Yeah. So, Sharon, maybe you could tell us a little bit about cyclosporin and the impact that it had on the entire field of transplantation.
Well, the introduction of that drug into immunosuppression had an absolutely huge impact, with survival rates increasing from the 40 or so % rate at 1 year up to 60 to 70% after that. Phil was actually the guy who managed to get hold of the drug and get us involved in the first clinical trial. The drug had been used in kidney transplants in the decade previously, and we were the first ones who introduced it in heart transplantation and published the paper that documented the improvement in survival rates.
I sense that there's another story behind this on how that drug actually came from Europe to the United States.
Well, yeah, I guess so. I don't know how interesting it is, but I think in 1978, and I was still a pretty young whippersnapper at the time, but Dr. Shumway let me go to a meeting in Rome of the Transplantation Society, which contained all the basic science immunologists that were interested in transplantation, as well as all the prominent clinical guys. A big meeting, right? And there were liver, kidney, a few heart transplanters at that time, at that meeting. So at that meeting, a guy named Roy Kahn, who's an Englishman, presented results in 20 or 25 kidney transplants that he'd done using this drug, cyclosporin, which had been developed in Switzerland by an outfit called Sandoz Pharmaceuticals. It's now Novartis, which I'm sure many of you know the name. And there were two guys there, one named Jean Burrell, another named Eric Wiscott. Wiscott was a chemist and Burrell was an immunologist. And they came along, they were at this meeting where Roy Kahn presented his kidney transplant series. And of course, that little session that he had was just jam-packed with people. And Burrell was kind of like a fish out of water. I mean, he hadn't been in transplantation before, and so he was hanging around the back, and people knew who he was, were all over him trying to get this drug, for Tom Starzl, who was one of probably the most prominent liver transplant guys in the country, just died a year or two ago, but did hundreds of liver transplants back in Pittsburgh, your competing center back in Pennsylvania. So everybody was trying to get it. So get this drug from John Burrell, who was the scientist at Sandoz. So it happened, that at this meeting they have these evening sessions where they take a crowd of people out to big dinners at some not chateau, that's France, but wherever they got in Italy. And so I got on the bus, and I was a little bit early, and here were these two guys sitting there up there on the bus by themselves. Nobody else was there, so I just went up and sat behind them and started talking to them, and befriended them, and they were kind of happy because they were unfamiliar with it. And of course, I was kind of nobody at the time, and probably still obtains. But anyway, so one thing led to another. I spent the evening with these two guys, and then, of course, broached the subject with them that maybe, for a heart transplant center, they maybe want to get going with us. I think at that time, there was hardly anybody else in the world doing transplants. There was a guy named Cabral in Paris who was a great friend of Shumway's from Minnesota, who did a handful, over a few years, and Dick Lauer, who was with Shumway when they more or less invented the procedure. He was back in Virginia. Maybe was doing a small number, but that was about it. So we were the only game in town for heart transplant, so they said okay. And so one thing led to another. We got the drug, first got in late '78, just little bottles of this powder for use in the lab, right? And that's the stuff that Bruce was used in the heart lungs in the monkeys in the lab. And then it took about 2 years until the end of 1980 to get it through all the approval procedures and the FDA and everything to get it finally done. So at the end of December of 1980, we did the first heart transplant with cyclosporin. That happened to be, we did one operation that you didn't mention called a piggyback heart transplant. So we were getting ready to do it, and we had a fellow who was dying, young guy, 27 years old with pulmonary edema. And the only donor available was a 12-year-old girl. So there was quite a size mismatch, and plus the young kids, their hearts are a little small for their size anyway. So the heart came back, and it was about that big, right? Size of a golf ball, maybe a little bigger. We thought this is never going to work. So we put it in a so-called piggyback and just put it in parallel with the patient's own heart. So this heart was hanging over in the right chest, the donor heart, and it was hooked up, the left atrium, the superior vena cava, the inferior vena cava we just sewed off, and then an outlet to the aorta and to the pulmonary artery we hooked up because we took a little extra pulmonary artery graft to stretch from the right side over to the left. And so that actually worked, and that young guy survived. The heart was doing mostly the work of the left side. The right side was not doing quite as much work. His own native heart was doing more of that blood flow, which I think changed over time, and Sharon might be able to talk about that further if she can remember how that worked. But he went on to live about 7 years, I think, after that, the first cyclosporin patient. And I think he was the second piggyback that we ever did at Stanford. The first one was also a young kid that didn't make it out of the hospital.
So it probably made for a very interesting X-ray and echocardiogram.
Yeah.
And EKG, right?
Well,
And a very
that
challenging
operation,
heart biopsy.
that piggyback operation was actually proposed first by Chris Barnhart, who nobody's mentioned yet today, who beat us out by a month or so of the first heart transplant in the world in South Africa, as many of you may recall. But he devised this piggyback operation. They had a lot of trouble with rejection and people going out to the boondocks and not getting medical treatment. So he did some of those, and he had one actually come back, and the heart was rejected, but the patient's own heart had kind of recovered, so he took it out. But there were a flurry of those, but they had some disadvantages and never really took off.
Very exciting.
Very much.
So we've talked about rejection. Oh, actually, I wanted to say, so you had a great meal, but
Great
you
meal
didn't.
at one of those palazzos, they
Yeah.
call them, or something.
But you didn't come home with a vial of medicine
come
in
home with it,
your
yeah.
luggage and
But they
didn't have to
sent
worry
it
about
along-
TSA.
They sent along pretty quickly within a month or two. But
Well,
of
you
course-
must have charmed them.
Well, it's the right place, the right time, just like it so often is.
So we've talked about cyclosporin and we've talked about rejection, but I think one of the things that we should also talk about is how Stanford was really instrumental in developing the means to monitor patients for rejection via the biopsy forceps, and also one of your very close partners in all of this, Dr. Billingham.
Yes, there was that decade after 1969, really, when there was an unofficial international moratorium on doing heart transplants because the initial results were pretty terrible. And during that time, Stanford was really the only really active program, as Phil said, doing transplants. And one of the major improvements during that decade was the introduction of the heart biopsy that was introduced by a Scottish surgeon who was in training with us at the time, a guy named Philip Kees, and he took an old Japanese bioptome, an instrument to take heart biopsies, and modified it to be able to be put in through the jugular vein in the neck and guided under fluoroscopy to the inside of the heart and be able to snip off small pieces that we could then look at under the microscope. That in turn led to the need to know what the heck we were looking at under the microscope. So Dr. Shumway then recruited a pathology resident who he thought looked underemployed. And my colleague, Margaret Billingham, ran away with it and created a biopsy grading scale that helped us interpret what we were seeing when we biopsied the heart. That has stood the test of time and has been codified into what is now an internationally accepted grading scale that goes from 0 to 3 and grades how bad the rejection is. Even today, we're working on ways to better non-invasively diagnose rejection, but right now that remains pretty much our standard of care.
So you didn't mention what we did before the bioptome, right? So you remember every patient had an EKG twice a day, 7 days a week, and somebody'd come in, twice a day and measure the voltages on how tall the little spikes in the EKG were, and with rejection they tended to shrink somewhat, right? So once these EKG voltages shrank, then they'd get repeated. But that was very laborious and not terribly accurate. And in those days, people rejected. Nobody left the hospital without rejecting at least once or twice, or and usually within the first week or two, almost everybody rejected. Whereas today, with advancements in various things, I think maybe 10, 15% of patients reject in the first year at all.
That's true.
But in those days, detecting rejection was quite a problem in the bioptome. There was a German, remember the German mechanical engineer guy named Werner Schultz?
Oh, yes.
Is the guy who, Phil Kees, who was the surgeon who was developing the bioptome. He recruited this guy, and he could make these teeny little clippers so for years, that guy...
He did them out in his garage, as I recall.
Out in his garage.
Garages are great places in Palo Alto.
The guy came down from Williams or somewhere north of Sacramento.
Yeah.
Yeah.
So before I turn it over to the audience, I just want to ask Dr. Reitz one last question, and it's a little different than what I would ask you. The two of you spent basically your entire careers here at Stanford, but Dr. Reitz, you were recruited to Johns Hopkins, a very famous institution on the East Coast. Could you tell us a little bit about what that was like to move from Stanford to Hopkins, and what was it like at Johns Hopkins, and how was it different? And then what was it like coming back to Stanford?
That's a complicated question. But I guess the first point is that Dr. Shumway had such an effect on so many people that he trained, and we're examples of that. And that environment in the 60s, 70s, and early 80s was just unique because no one else was involved in a project like this that was so all-encompassing. The people that established Margaret Billingham, for example, whatever the area was in heart transplantation, the leader came from the group somewhere. And that environment friendly to learning was very effective. And I should also mention Ed Stinson had a lot to do with that, the overall leader of the team, getting an NIH grant that covered both laboratory work and clinical work, which was just unheard of at that time, and had it for more than 20 years. But anyway, I was like everyone else that came through at that time with their own project. was presented with the opportunity to go to Hopkins. And I also had a very good friend, an extremely fine man surgeon by the name of Bill Baumgartner. And he and I had been residents together, and had pretty much decided that if we were going to ever leave Stanford, we might try to do it together because we worked so well together. So only with the caveat that Bill would come with me, I accepted to go to Hopkins and try to establish a Stanford of the East in Baltimore, which, as you might imagine, and people in medicine here know, it's just a different environment in an Eastern institution at that time than it was at Stanford, where people that are as young as we were given responsibility and allowed to blossom, so to speak. It's a much more regimented system. So we hope to introduce some of the same environmental things that we had at Stanford, the excitement of what we were doing, combining the lab with what we would take to the OR. And I think over a period of time, we had some success in doing that. And certainly after I left and came back, Bill took it steps further as well. But it was a lot of fun to bring Stanford a little bit to the Eastern institution environment. And Hopkins is a place that values people who are very committed to what they're doing in the care of patients. And they responded very well, I think, to cardiac surgery, and it gained some more prominence within the institution. It was a very different institution because cardiac surgery was just a fragment of this huge operation. At Stanford, cardiac surgery was about a third of what happened in the hospital. But it was a fun 10 years, and we interacted with a lot of people, had a lot of great residents, and had a little bit of an impact on your life, I think.
More than a little bit. What Dr. Reitz is alluding to is that despite his young age at the time when he went to Hopkins, and I'll ask you to answer that question, he actually trained and worked with individuals who then went from Johns Hopkins to the University of Pennsylvania. And those individuals were very instrumental to my training. So I was indirectly trained by Dr. Reitz. And in fact, I still remember to this day several things where those individuals would say, this is how Dr. Reitz would do it. And it was very interesting for me to come back to Stanford. So in a way, you're sort of my career grandfather. But perhaps you can tell the audience, you're too modest, but how young you were when you went and became the leader of the world-famous Johns Hopkins University program.
Well, I was 38, which was young for the time.
Very young.
It was also typical of other people that left Stanford and went places. Randy Greep, Jack Copeland. People would leave Stanford with the training that we had here with Dr. Shumway and became chiefs of their departments wherever they went. So that was another part of Norm's enormous legacy, was the people that he trained, and then the second, third generation after that are still going on.
Well, I can certainly say I think we all owe Dr. Norman Shumway an amazing debt of gratitude.
Bruce, I think you were the youngest chief of cardiac surgery anywhere, or at Hopkins at least, till Ben Carson came along.
That could be. I also have a connection to Ben Carson, but I don't think I have enough time to talk about it. Because we did do one case together that got written up, and it was the separation of Siamese twins joined at the back of the head. So they needed cardiopulmonary bypass and circulatory arrest in order to separate, which was a big boost to his career at the time. But that was the only...
So we have microphones out there, and we would welcome questions of any sort.
Okay.
So you mentioned cyclosporin, which was kind of a miracle drug at the time, but it did have its limitations, its toxicities. And I'm wondering, what is the current state of the immune suppressions now? And are you at the point where you can wean patients off of immune suppression drugs or not? That was kind of the sort of holy grail, once you had patients living 5, 6, 7, 10 years.
So cyclosporin is still used and still available. It's been succeeded by another drug called tacrolimus, which we use much more routinely these days, but it has very similar toxicities. It's toxic to the kidneys, it can promote diabetes, etc. We're in crucial need of more different and better things, and they are coming. Regenerative therapies may be part of it. Other drugs, ultimately the holy grail will be immune tolerance, where we figure out how to not carpet bomb the immune system, but just to very specifically suppress immune reaction to a specific donor. We're a ways from doing that, but to answer your question, immunosuppression currently, while it lightens up over time, is pretty much a lifelong commitment for patients.
Question is over here on your left.
You talked about people coming and going, and there's somebody who overlapped with my training here, Von Starnes, and I was just wondering, I saw he was on one of the papers, just comment about his role and also his leaving. Any reaction to that?
Well, Vaughn was here when we did that first LVAD. By the way, that wasn't the first LVAD ever done in the world. There were a handful of others at other places, Texas Heart Institute, but none of them successfully, at least in terms of the patient making it through the whole implant and transplant. So nobody had one survive until that first one we did at Stanford. So that year we did that, which was in 1984. Von Starnes was a first-year resident here. He was sort of a junior resident when we did that first case. And he'd come, I think, from Vanderbilt. And he just finished the general surgery training. So the way we put that in was a little unusual. We put the graft to the belly aorta, and I can remember those days. He was great in general surgery, so he knew better than I did how to get to the abdominal aorta, right below the diaphragm. So anyway, he helped do that first case. And then he came on the faculty 2 or 3 years after that when he finished his training, probably 87 or so. I can't remember how long he was here, but he continued on doing lung transplants when he was here. And eventually USC made him an offer he couldn't refuse, so he went down there as chief at USC, and now he's the dean or something down there,
And one is
still not quite active.
If I might add, one of the things that he did at Stanford that was fairly unique was the related donor lung transplant.
Yeah.
He was doing children, and the lobar, a portion of a lung of an adult, usually the parent, put into a child because of their severe lung disease. And that was a unique contribution that Von made while he was here at Stanford.
This question is here at the center towards the back.
Stand up. Much was made of the race between Dr. Christian Barnhart and Shumway in terms of the first heart transplant. Talk a little about what the community was like after those initial few heart transplants. How did the knowledge be shared and more people become trained in the area, and really, rather than being a competitive platform, maybe more collegial, so that more discoveries could be made and more sharing of knowledge? What was that like, and was it an international world, or was it more confined to certain medical centers and so forth?
Well, So after that first, Barnhart, of course, did his in late '67, and this one happened in a month or so later. And subsequent to that, I think before that time, I don't think there was any conscious race going on. I think Barnhart he'd spent time in Minnesota. He came out here at one point for a visit back in '67, and the operation itself isn't really very hard, right? So he made a whirlwind tour and sort of went back and did it. And I don't remember too much about interaction here with Chris Barnhart, with Shumway. I think they were probably a little at odds.
I don't think they had any real interaction.
Yeah.
But Dr. Shumway had already indicated, maybe as much as a year before, that he was actually going to do it in human patients, so it was well publicized.
Yeah.
And I think that may have had a role in spurring Chris Barnhart to try to do the operation sooner.
That's possible. But then as far as the other part of your question in regard to teaching other people, so after that first transplant, within the next 2 or 3 years, 150 or more of those of heart transplants were done at 50 or 60 centers around the country and maybe the world. And we used to have a slide showing that great upsurge in 69, 70, 71. But that curve went down in the early 70s as quickly as it went up because hardly anybody survived. The operation, itself straightforward, so any cardiac surgeon could do it, and so a lot of them tried it. And so, without very good results. And there's an old slide we used to have in the front of Life magazine that Dr. DeBakey in Texas declared heart transplant to be dead. But of course, Dr. Shumway soldiered on through that and basically learned. Now, during that period of time, I can recall that every year must be several hundred visitors would come and to visit Stanford to look at the program, see how things are being done through the 70s. And eventually, Dr. Shumway would, if people would call up, say, can we come? Shumway would say, yeah, sure, come on out. But he didn't spend any time with them much. He'd shun them off to cardiology. And Sharon may remember that, but Dr. John Schroeder, who was active back at that time as a cardiologist. So they finally got too burdened by it. So we sort of had 1 or 2 meetings per year where all they would say, if you want to come out, you can come and we'll give you a 3-day course, how we do things and what the current status is and so forth. So that continued to happen for several years until eventually, we taught everybody, I guess, that wanted to learn.
Well, ultimately, it all gelled into honest-to-God training programs where people would come out and spend a year or 2 and learn how to do things, which is where we are now. In transplant cardiology, as of the year 2010, we have been board certifiable by our certifying agency, the American Board of Internal Medicine. So we have over 1,000 transplant cardiologists. Prior to that, it was pretty much ragtag training. And not that it wasn't good training, but it wasn't very organized.
Thanks for this fascinating overview of an important history of heart transplant. I'm curious about the role of computer modeling and perhaps how that may have changed some of these dramatic innovations, and in particular with regard to the real with the virtual or the actual with the virtual. Is it on the horizon, for example, with the brain in the box, perhaps in the Google Project Baseline, to create a virtual heart in the box, transport it to an Australian outback site, and even do something like telerobotic surgery, real virtual correspondence as it might emerge in even a Google Street View environment. Thank you.
That's for Joe.
That's Joe.
That's for Joe.
Well, I think there are some applications of artificial intelligence, or at least facilitated intelligence in medicine now. For example, One of the really exciting things that's going on with Sharon's group and with one of her partners is finding out a means of detecting rejection well before you would detect it with a biopsy and without the need for a biopsy. So their group has developed a means of detecting serum-free DNA in the blood. That DNA would reflect breakdown of some heart cells. And that's a really exciting area of research and potential clinical application. And I think integrated into that would be the use of multimodality imaging. So we heard about Dr. Oyer's measuring of the EKG, but things like that can be measured across every piece of data you can imagine by a machine. So an echocardiogram, an EKG, all of that can be inputted into some big data repository, and you probably could monitor heart function much better than with biopsy. So there's things like that going on. I can't say that we've really gotten that far. The way you think of artificial intelligence, we're really not quite as far progressed in transplantation as you might imagine. And I haven't heard about brain in a box yet.
Yes, I know that Dr. Shumway was very active sometimes in going to Sacramento to argue about animal models and research, and I know that that's always been a matter of social controversy. Can you tell me how important animal models are now, and how you think how important will they be in the future?
Well, I think they're much less important now for heart transplantation for sure than they were in the past. I mean, the culture has changed tremendously since I was in the lab, and actually, some of my work in the lab involved transplanting dogs and used different immunosuppressants, right? And I think that year I used maybe 400 dogs, half donor, half recipient. And that's where I learned how to operate, number one, because if you can sew a dog's aorta together and not have it leak, those things are pretty fragile. So you become, so that's where I learned to operate. But more than that, I mean, today you can't do that. I mean, back in those days, they had the dog pound, they called them, right? And they'd deliver 30 or 40 dogs, and they'd put them on the roof of the hospital where they kept these dogs. And we could use them. So I mean, it's today you just can't imagine how things, that is what happened. But so I don't think today the animal models are quite as important to, I mean, the technology, the techniques of how you do it are pretty well standardized now. I mean, the one thing we didn't mention today, though, is with respect to animals, is so-called xenotransplantation, which means from an animal to a human. Now, of course, that was done down at Loma Linda 20 years ago by Len Bailey with a primate to a baby. But there are still people in the world who've dedicated their lives to overcoming the problems. Obviously, rejection is number one, and if you just take a pig heart and put it into a human, they'll reject within minutes. So that barrier has pretty much gotten over if people figure out how to change the genetics inside the pigs so that they don't express antigens that humans can attack immediately, right? But you're still left with sort of the basic rejection, and people are making progress in that. So down the line, and Joe didn't mention in his future talk either, I don't think he's very sold on the idea. But, and Dr. Shumway wasn't either. I remember going to a meeting in Rome once, another meeting in Rome. Chris Barnhart was there on a panel similar to this one. And he said, well, he thought xenografts would be being done routinely within 10 years from that. That was back in 1978 or 80 or 81. Shumway always said that xenografts are the future of heart transplantation and always will be. So, but I think we are potentially closer to that, in which case the donor shortage that Joe talked about, could be alleviated.
Okay. Well, I'm being signaled from my team that the event is drawing to a close, at least the panel is. So may I ask all of you to join me in once again thanking our panelists for their incredible pioneering and their sharing these wonderful stories. Thank you very much.